Today, we're talking of an important and often misunderstood subject: how obesity itself can affect female hormones and fertility, quite apart from the polycystic ovarian syndrome or PCOS. For years, when we saw a woman with obesity and irregular periods, the default label was PCOS. This new review in the Endocrine Reviews asks us to think differently. It proposes that just as obese men can develop specific form of low testosterone called as male obesity-related secondary hypogonadism, obese women may have a parallel condition, non-PCOS female obesity-related secondary hypogonadism, or FOSH. That's something which is new. Why does this matter in practice? The data shows that menstrual disturbance becomes as much common as BMI rises. Around 14% of lean women report cycle problems, but this grows to over 60% of BMI, or 60 kilogram per meter square. That's far more to blame on PCOS alone. Detailed hormone studies reveal that in obesity, LH pulses from the brain are weaker, mean LH levels fall, LH pulse amplitude is roughly halved, and mid-luteal progesterone can nearly drop fivefold in severe obesity compared to lean women. That's again, as weight increases, progesterone levels also start dropping. Ovulation may still occur, though of poorer quality. The mechanisms are complex but clinically intuitive. High insulin, raised free fatty acids, chronic low-grade inflammation, and leptin resistance all coverage on the hypothalamus and pituitary to blunt the GnRH and LH secretion and increase the LH clearance. At the same time, androgens rise in many obese women even without PCOS, and high levels of those androgens can actually suppress LH further. AMS does not behave in the classic high PCOS pattern either. In obesity, it is often normal or reduced and may fall with weight loss. The good news is that this process at the least is reversible. After significant weight loss following bariatric surgery, or maybe taking things like Mounjaro or Ozempic, around 80 to 85% of previous oligomenoric women with irregular cycles have regular menstrual cycle and androgen levels fall. For clinicians, the message is clear. Don't assume every obese woman has irregular cycles has PCOS. Consider whether obesity itself is suppressing the reproductive axis from the brain. For patients, it means meaningful weight loss, whether life-based, pharmacological, or surgical, not just about long-term health risks. It can directly improve hormone signaling, ovulation, and fertility.